Okay, a very warm welcome to our course director, moderator, panelists, and all participants. I am Diana, your MC for today's webinar. To start things off, I would like to express my gratitude to all members of the Society of Endolaparoscopic Surgeons who are consistently present virtually, even though the seemingly endless pandemic has held us from having a face-to-face interaction. Regardless of the situation we are in, we must always continue to refresh our knowledge, parallel to the constant development of technology. And so, for the time being, we meet again in this ISES webinar, this time in collaboration with Olympus. I thank the Honorable Erawan Widiasurya MD as the President of the ISES, Barlian Suteja MD as our Course Director, and Julius Anggara MD as the Head of the North Jakarta Indonesian Medical Association. And I also thank our speakers today, Reno Rudiman MD from Indonesia, Prof. Asim Shabir, MD from Singapore, and Prof. Alan E. Buenaf, MD from the Philippines. Many thanks for Olympus for supporting today's events, Ms. Mei Ying Yam and Mr. Yendi Arif for joining us today. Before we begin, I would like to thank all of you for making the time to join us in today's ISES webinar with the theme Indonesia Virtual Masterclass Upper GI Course, Bleeding Prevention and Management. The program for today's events will be as follows: an introduction to the live webinar by our course director, Barlian Suteja MD, an opening and welcome speech by the president of the ISES, Erawan Widiasurya MD, medical ethics by North Jakarta Indonesian Medical Association, an overview of upper GI bleeding by Reno Rudiman MD, PhD, TB energy use by Assistant Prof. Asim Shabir MD, the endolaparoscopic management of upper GI bleeding by Prof. Alan E. Buenaf MD, a Q&A chat, and a closing lecture session. A gentle reminder for our participants to please fill out the Q&A column for any questions during our sessions. Now, moving along to our session, please welcome our moderator, Barlian Suteja MD, who will provide an introduction to today's live webinar.
Okay. Thank you very much. Thank you very much for your nice introduction, Dr. Diana. And dear distinguished Dr. Erawan Widiasurya, President of Indonesian Society of Endolaparoscopic Surgeons, dear distinguished Dr. Julius Anggara, President of North Jakarta branch of the Indonesian Medical Association, dear distinguished multinational speakers, Dr. Reno Rudiman, Prof. Asim Shabir, Prof. Alan Buenaf, dear distinguished participants, and also dear panelists, Dr. Erawan Widiasurya, Dr. Kunsmedis Tiadi, Dr. Muhammad Iqbal Rifai, and Dr. Ahmad Sumaro. And we will today start with our program. Assalamualaikum warahmatullahi wabarakatuh. Good morning, and once again, very warmest welcome to our lecture webinar in Jakarta, Indonesia. Today's webinar topic is upper GI course about bleeding prevention management. This is as a first webinar on the Indonesian Virtual Masterclass Series program arranged by the Indonesian Society of Endolaparoscopic Surgeons, ISES or PBI, and supported by the Olympus company. Today, we are very proud and very honored to have many distinguished multinational faculty to share their expertise with us. And so please allow me to express my special thanks to all of you. My thanks also go to Olympus company for their support and also to the organizing committee for their hard work. And I wish you a fruitful webinar and stay healthy. Thank you very much. So please.
And
next speaker. Next, welcome speech from Dr. Erawan, please.
Thank you, Doc. Now for an introduction from Erawan Widiasurya MD as the president of the ISES as he delivers an opening and welcome speech. Please, Dr. Erawan.
Thank you, Dr. Diana. Widiasurya, not Widiasurya.
Sorry, Doc.
Okay. Okay. First of all, I would like to have my gratitude to my friend Ellen Bunafe and also Ashim Shabir, all the professors. It is our honor that you can speak here again. For Ellen, you are many times to talk here in Indonesian webinar, and also my gratitude also to Dr. Reno as the speaker. Dr. Barlian Suteja, of course, my brother for the course director. All the panelists here, Dr. Kunsumedi, Dr. Aro Zumaro, and Dr. Iqbal, and all the participants. So this is our Indonesian, and also, sorry, to the Dr. Julius. Dr. Julius is from the Indonesian Medical Association of North Jakarta. And I would like to say that this is our 6th Indonesian Society of Endolaparoscopic Surgeons webinar. And then for the master class, this is for the first time. And I hope that we can continue this master class with maybe after after Lebaran after around June, or I think around June, for the hepatobiliary and others, and followed by colorectal and so on and so on. Bariatric also, for maybe for hernia also. It will be continue our master class webinar. Then I think that we have already the participant now registered around 700, but now still here the present about 262 participants. So in this case, I would like to say happy meeting for this moment and wish you a fruitful meeting. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Erawan. And now we continue to Julius Anggara, MD, as he addresses medical ethics.
Terima kasih. Salam sejahtera dan salam sehat untuk kita semuanya. Yang saya hormati penyelenggara acara ini, Dr. Erawan dan Dr. Barlian Suteja. Dan yang saya hormati para panelis, para pembicara, dan para peserta webinar masterclass pada hari ini. And thank you for Professor Ashim Shabir and Professor Ellen Bunafe as a speaker in this masterclass webinar. Pada pagi hari ini, saya mendapat tugas untuk membawakan topik tentang etika kedokteran dan praktek sehari-hari. Izinkanlah saya share screen ya. Sudah jelas? Saya akan memulai. Seperti kita ketahui, dalam praktek sehari-hari pada zaman sekarang ini banyak masalah yang timbul karena ada pelanggaran daripada etik kedokteran. Untuk itu, PBID mewajibkan setiap webinar yang ber-SKPID untuk memberi etika kedokteran pada setiap webinar. Saya akan memulai dengan etika dalam praktek kedokteran. Etika dan praktek kedokteran kita dapat membaca di buku saku kecil yang diterbitkan oleh Pengurus Besar Ikatan Dokter Indonesia, di mana dalam buku kecil tersebut berisi tentang hal-hal tentang kewajiban umum, kewajiban dokter terhadap pasien maupun terhadap teman sejawat dan diri sendiri. Dan di dalam buku kecil ini terdapat pasal-pasal yang nanti saya akan uraikan secara singkat supaya sekedar mengingatkan teman-teman sejawat semua, karena saya yakin teman-teman sejawat semua sebenarnya sudah pernah membaca dan ini hanya sifatnya mengingatkan. Kita mulai dengan kewajiban umum. Kewajiban umum. Seorang dokter dan melakukan pekerjaan kedokterannya tidak boleh dipengaruhi sesuatu yang mengakibatkan hilangnya kebebasan dan kemandirian profesi. Kedua, setiap dokter wajib menghindari diri dari perbuatan yang bersifat memuji diri. Tiap perbuatan atau nasihat dokter yang mungkin melemahkan daya psikis maupun fisik wajib memperoleh persetujuan pasien atau keluarganya dan hanya diberikan untuk kepentingan dan kebaikan pasien tersebut. Setiap dokter wajib senantiasa berhati-hati dalam mengumumkan atau menerapkan setiap penemuan teknik atau pengobatan baru yang belum diuji kebenarannya dan terhadap hal-hal yang dapat menimbulkan keresahan masyarakat. Seorang dokter wajib memberi surat keterangan dan pendapat yang telah diperiksa sendiri kebenarannya. Seorang dokter wajib bersikap jujur dalam berhubungan dengan pasien maupun sejawatnya dan berupaya untuk mengingatkan sejawatnya pada saat menangani pasien dia ketahui memiliki kekurangan dalam karakter atau kompetensi atau yang melakukan penipuan atau penggelapan. Seorang dokter wajib menghormati hak-hak pasien, hak-hak sejawat, dan hak tenaga kesehatan lainnya, serta wajib menjaga kepercayaan pasien. Setiap dokter wajib senantiasa mengingat kewajiban dirinya melindungi hidup makhluk insani. Kita menuju kewajiban dokter terhadap pasien. Seorang dokter wajib bersikap tulus dan ikhlas dan mempergunakan segala keilmuan dan keterampilannya untuk kepentingan pasien. Yang ketiga, ketika ia tidak mampu melakukan suatu pemeriksaan atau pengobatan atas persetujuan pasien atau keluarganya, ia wajib merujuk pasien tersebut kepada dokter yang mempunyai keahlian untuk itu. Setiap dokter wajib memberikan kesempatan pasiennya agar senantiasa dapat berinteraksi dengan keluarga dan penasehatnya, termasuk dalam beribadah atau penyelesaian masalah pribadi lainnya. Setiap dokter wajib merahasiakan segala sesuatu yang diketahuinya tentang seorang pasien, bahkan juga setelah pasien itu meninggal dunia. Setiap dokter wajib melakukan pertolongan darurat sebagai suatu wujud tugas pri kemanusiaan, kecuali bila ia yakin ada orang lain yang bersedia dan mampu memberikannya. Selain itu, kewajiban dokter juga terhadap teman sejawat. Setiap dokter memperlakukan teman sejawatnya sebagaimana ia ingin diperlakukan. Setiap dokter tidak boleh mengambil alih pasien dari teman sejawatnya, kecuali dengan persetujuan atau berdasarkan prosedur yang etis. Selain itu, kewajiban dokter juga ada terhadap diri sendiri, yaitu setiap dokter wajib memelihara kesehatannya supaya dapat bekerja dengan baik. Bila dokternya sakit, mungkin ya pekerjaan yang dilakukan tidak akan menjadi baik. Setiap dokter harus senantiasa mengikuti perkembangan ilmu pengetahuan yang seperti terjadi pada hari ini dan teknologi kedokteran atau kesehatan. Yang sering terjadi pada sengketa medis adalah antara dokter dengan pasien atau rumah sakit dengan pasien, di mana kalau masuk ke dalam ranah hukum dibagi 4, ada perdata, pidana, etika, disiplin. Biasa perdata itu yaitu tanggung jawab rumah sakit, ada dalam pasal 46 Undang-Undang Rumah Sakit, karena yang dituntut ada rumah sakit. Tapi kalau udah masuk ke dalam pidana, etika, disiplin, biasanya dokternya sendiri yang akan menanggung karena dokternya merupakan pelakunya atau operatornya. Permasalahan yang sering diadukan, yang paling penting yang pertama yaitu sering terjadi yaitu miscommunication, komunikasi yang tidak baik, sehingga pasien merasa tidak puas bila terjadi hal-hal yang tidak diinginkan, maka pasien akan menuntut. Kalau komunikasi antara dokter dengan pasien baik, biasanya hal-hal yang besar akan dapat menjadi hal yang kecil dapat ditiadakan. Ingkar janji, penelantaran pasien, pembiayaannya tidak sesuai, standar pelayanan, kompetensi yang sesuai, iklan dari dokter dilarang mengiklankan diri secara pribadi kecuali atas nama suatu institusi atau rumah sakit. Dalam praktek sehari-hari ada 3 pilar yang penting dalam kita melaksanakan praktek. Yaitu pertama, harus seorang dokter praktek sesuai dengan kompetensi profesional, dan sesuai kompetensinya. Kedua, hubungan, yaitu hubungan yang baik antara dokter dengan pasien maupun dengan teman sejawat. Nah, itu dengan pasien yaitu etika individual antara dokter dengan pasien, antara sejawat, dokter dengan sejawat yaitu kesejawatan dan etika sosial. Yang ketiga yaitu etika profesi. Nah, norma dalam praktek kedokteran itu ada 3 hal, yaitu etika, disiplin, dan hukum. Dan etika, disiplin, dan hukum itu tidak dapat dipisahkan antara satu dengan lain. Di antara etika, disiplin, hukum itu semua itu saling keterkaitan dalam hal tersebut. Sumber daripada etika kedokteran sebenarnya diambil dari Sumpah Hipokrates pada tahun 460 sampai 377 sebelum Masehi. Kemudian diadopsi pada saat sumpah atau janji dokter waktu saat dilantik menjadi dokter, di mana hal-hal tersebut ini semua ada di dalam etika kedokteran. Nah, antara lain sumpah janji yaitu demi Allah saya bersumpah atau berjanji bahwa saya akan membaktikan hidup guna kepentingan peri kemanusiaan, memelihara martabat dan tradisi luhur kedokteran, menjalankan tugas secara terhormat dan bersusila, merahasiakan segala sesuatu terkait profesi sebagai dokter dan tidak akan menggunakan pengetahuan dokter untuk sesuatu yang bertentangan dengan peri kemanusiaan, menghormati setiap hidup insani sejak pembuahan. Jadi sumpah atau janji dokter ini ada dalam etika kedokteran, cuma di dalam etika kedokteran ada dicantumkan pasal-pasalnya. Mengutamakan kesehatan pasien dan kepentingan masyarakat, berikhtiar dengan sungguh-sungguh tanpa terpengaruh oleh pertimbangan keagamaan, kebangsaan, dan seterusnya. Menghormati dan berterima kasih kepada guru-guru. Saya memperlakukan teman sejawat sebagaimana saya sendiri ingin diperlakukan. Ikhlas dan sumpah janji ini dengan sungguh-sungguh serta pensapan dan tanggung jawab dengan mempertaruhkan kehormatan diri saya. Penjelasan kenapa ada sumpah dan janji karena bagi yang tidak mengucapkan sumpah, kata sumpah dapat diganti dengan janji. Nah, mungkin ini hal-hal dari sumpah kedokteran, etik ada di dalam etik, cuma di dalam buku kecil etik kedokteran dipelengkap dengan pasal dan ada keterangannya dan sebagainya. Dan bila kita melaksanakan semua yang ada di dalam buku etik kedokteran itu, insya Allah dalam praktek sehari-hari itu kita tidak akan menemui hal-hal yang menyurutkan kita. Terima kasih, mungkin karena waktu yang diberikan cuma 10 menit, mungkin ini hanya refreshing, dan untuk selanjutnya kalau yang kurang jelas bisa dibaca pada buku kecil Kodeki yang diterbitkan oleh PDID. Terima kasih, waktu dan tempat saya kembalikan kepada moderator. Terima kasih, Pak Moderator.
Ya, silakan. Jadi, terima kasih Dr. Julius atas uraiannya mengenai etik yang mana kita semua harus mengikuti presentasi ini sebagai salah satu oleh PBID. Terima kasih sekali lagi atas presentasi Anda yang jelas, ya, dan semoga tidak bosan-bosan untuk memberikan presentasi tersebut pada kita semua. Thank you. Thank you very much, Dr. Julius. We move to our main congress or main course in this. Yeah. Before we start with Dr. Reno with the lecture, I would like to try to and also to say thanks to our panelists. First, Dr. Erawan Wiradisuriya. Please CV from Dr. Erawan Wiradisuriya. Everybody here or participant know him very well. I cannot tell the story from him. It's quite a long list of the appointment, and he is now currently as a president of Indonesian Endolaparoscopic Society, and also Secretary General of Indonesian Hernia Society, and other appointment also. Dr. Erawan is a very experienced laparoscopic surgeon in Indonesia, and as a panelist, I hope he can contribute to our course today very well. And the second panelist is Dr. Reno, also not Dr. Reno, as Dr. Kun Semedi. Kun Semedi is also a laparoscopic surgeon with special interest also in the endoscopic surgery. And he, with Dr. Reno, together as a pioneer to educate the general surgeon to get the experience or the in the field of endoscopy. Yeah, the field endoscopy. And Dr. Kun Semedi has a huge experience in his endoscopic surgery, and I hope today he can contribute to our course very well. Yeah, and the third panelist is Dr. Muhammad Iqbal Rifai from Padang. He is a young rising star from our laparoscopic and endoscopic surgeon in Indonesia, and he is in Padang as a chief of the University of Fakultas Kedokteran Universitas Andalas. And Dr. KK had quite a lot of experience also in the endoscopic surgery, and I hope he can contribute also quite a lot of his experience in our discussion today. And the last one is Dr. Chumaro. He's also a brilliant rising star from the Military Hospital of Indonesia. He's ranked as a colonel in the military, and I hope he, with his experience, can contribute also quite a lot of things in our webinar today. So I thank all the panelists for your presence and also contribution for today's webinar. So thank you very much. And I would like to start with our first lecture from Dr. Reno Budiman. Reno Budiman, as you see here, he is a digestive surgeon consultant and from Hasan Sadikin Hospital in Bandung. He has a huge experience in laparoscopy and also endoscopic surgery, and is also a pioneer of the laparoscopic surgery in Indonesia and the endoscopic surgery in Indonesia as a surgeon. And he is also the pioneer of the robotic surgery. And today he will talk about the overview of the upper GI bleeding. Please, Dr. Reno, the time is yours.
Thank you, Dr. Barlian, for your kind introduction, and good morning to all audience. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Very warm welcome for our guests, Professor Asin and Professor Alan. It's very nice meeting you again, although only through virtual platform. Yes, today I would like to give speech on overview of upper GI bleeding. So upper GI bleeding is a potentially life-threatening condition that requires prompt and appropriate management. And more people are hospitalized for gastrointestinal bleeding than for congestive heart failure or deep venous thrombosis. Probably nowadays it's only superseded by the COVID-19 cases, which is still on the rise here in Indonesia. And upper GI bleeding is defined as bleeding from the source proximal to the ligament of threads and can be categorized as either pharyngeal or non-pharyngeal. So in patients with gastrointestinal bleeding, comorbid illness is the primary cause of death, not the actual bleeding itself. And as far as 50% of patients with bleeding and with low rate in men and then in women. And because rebleeding or continued bleeding is associated with higher mortality, prevention is the most effective strategy. Although it is common, however, through the time, it has been decreasing. One survey has revealed that the number is decreasing now, probably to the better of our medication and interventions. However, the mortality remains high, up to 11% of gastrointestinal bleeding fatal. So now we enter the pathophysiology. There are at least 4 classifications of causes of gastrointestinal bleeding, namely peptic ulcer disease, and then esophageal varices, stress-related mucosal damage, and other common causes. Now we enter the peptic ulcer disease. Peptic ulcer is the most common cause, and almost 40% of bleeding episodes are caused by peptic ulcer. And Helicobacter pylori and chronic use of NSAID, it's the predominant cause of the ulcer bleeding. And although most NSAID-associated ulcers are asymptomatic and do not lead to bleeding, elderly patients with history of bleeding are increased risk of rebleeding with continued NSAIDs. So that's the danger of drug. And specifically, probably in Indonesia, there are many herbal medicine probably contains some kind of NSAID in the ingredients. So therefore, many Indonesians also suffer from bleeding because of the herbal medicine or jamu-jamuan. The next case is the common cause of gastrointestinal bleeding is esophageal varices. It is the second most common cause of gastrointestinal bleeding, and 50% of patients with cirrhosis and pharyngeal hemorrhage, 5 to 15% per year, depending on the severity of the liver disease. And 6 weeks mortality with its occurrence of pharyngeal hemorrhage is about 15 to 25%. So it's quite high, really. The third case is stress-related mucosal damage, or probably more known as stress ulcer. Yeah. So stress-related mucosal damage usually common in ICU patient with critical illness patient. And there are 2 major risk factors for overt GI bleeding in critically ill patients. There are patients who are mechanically ventilated for more than 48 hours, and also patients with coagulopathy, which is defined by platelet of less than 50,000 per millimeter cubic and international normalized ratio of more than 1.5. Other risk factors are surgery, trauma, organ failure, sepsis, burns, severe burn, and neurologic injuries. Also the use of anticoagulants, high-dose corticosteroids. Those are the risk factor for causing a stress ulcer or stress-related mucosal damage. The last one is other uncommon causes. So the incidence is low, but it is still maybe life-threatening. Things like Mallory-Weiss tears, the incidence is around only 5%. It happens when a mucosal damage of the upper GI because of the profuse or forceful distension from coughing and cause the rupture of the artery. The next one is autoenteric fistula. Autoenteric fistula also, autoenteric fistula usually happens in patients with prosthetic of abdominal aortic vascular graft. So the graft is causing injury to the mucosa, and then it tears and causing bleeding of the upper GI. The last one is tumor of the upper GI tract. It's only less than 3% of all GI bleeding. Now we go on to clinical evaluation and diagnosis. The initial evaluations, complete medical history, physical examination, laboratory examination should be done. Medication history, it is important to know the history of medication for the patient, like NSAID drugs or herbal medicines in Indonesia probably, antiplatelet agents, usually patients with cardiovascular compromise regularly consume antiplatelet agents. For laboratory failure, there are non-specific really, only complete blood cell count, serum chemistry. Those are routine lab examination. It is necessary and useful to assess the severity of the bleeding. The most common clinical presentations, usually hematemesis, it covers about 30% of patients, and also melena, which is happen on 20% of patients. In patients with malarial tears, usually emesis, retching, and forceful coughing usually precede the hematemesis. Patients with presenting jaundice, weakness, you should suspect that there's a liver disease causing variceal hemorrhage. Patients with bleeding from malignant tumor usually presents with cachexia, as we know all about. Now, how about prognostic assessment? Prognostic assessment is useful for early identification in high-risk patients. The most common scoring used to assess the severity of the bleeding is usually with blood spot score. With blood spot score, when the score is 1 or higher, it means that patient is high risk for the complication and mortality. So as the guideline for management, I refer to this article published in 2019, the management of non-variceal upper GI bleeding. So this is a very useful guideline written by consensus of experts from all over the world. Regarding the management, the risk factor for cardiovascular compromise is using a ROCAL score, and because there are slight difference in managing a bleeding with patient with internal bleeding compromised with cardiovascular. So we should take into account the cardiovascular compromise. And the management is divided to three strategies. First, in the pre-endoscopic, and then endoscopic management, and then pharmacologic and non-pharmacologic management. In pre-endoscopic management, the Glasgow blood spot score that I explained earlier, it is useful to detect or to identify the risk of rebleeding who may not require hospitalization. If the score is low, then you don't need to hospitalize the patients. In patients without cardiovascular disease, the suggested hemoglobin threshold for blood transfusion is less than 8 grams per deciliter. But for cardiovascular disease patient, probably you need higher hemoglobin level. So you need more transfusion to ensure the perfusion of the oxygen reaching the tissue. The second management is endoscopically. Endoscopic usually performed within 24 hours of presentations. And endoscopy is not done only to diagnose the disease, but also to make therapeutic intervention. What things are used? This will be presented in the next presentation by probably Prof. Asim, and probably Prof. Allen also will elaborate on this. But things like thermocoagulations, clips, sclerosing injection, it is used, and usually hemostatic powder also useful for temporizing therapy. But for treatment, there are Yeah, I'm sure that it will be elaborated by our next speakers. Endoscopic management, although 80% of gastrointestinal bleeding resolves spontaneously without treatment, as much as 20% will recur. Endoscopy may be delayed for select high-risk patients, including those with acute coronary syndrome or suspected perforation. So in a very high-risk patient, probably we don't do endoscopic aggressively because we are afraid that it will make things worse. And how about the role of nasogastric lavage? To remove particulate matter, fresh blood, it is useful before endoscopy. And in most useful in hemodynamically stable patient without evidence of hematemesis, probably nasogastric lavage has a place. Fresh whole blood in nasogastric aspirate, it is a predictor for high-risk lesion. And during endoscopy, we can see a source of bleeding in one of these classifications by Forrest. Forrest classification is frequently used to assess the risk or the ongoing bleeding. If the bleeding is spurting like this, it is Forrest 1A, then probably it is difficult to manage by endoscopy. Sometimes or most of the time the patient will convert to surgery to stop the spurting bleeding. But for Forrest classification 1B with oozing bleeding like this, probably endoscopy may have a place to stop the bleeding with hemostatic agents and any device of the endoscopy that we may have. The other, Forrest 2A, 2B, or to see, you don't need probably a further treatment because the bleeding has actually stopped. And also in Forrest classification 3, there is virtually no more bleeding. So probably you can continue to pharmacologic treatment after the endoscopy. In non-pharyngeal bleeding, for the pharmacologic management is like this. So this is the algorithm. You identify the patient either as low risk or high risk. In high risk patient, you need endoscopic intervention and PPI therapy. And surgery has a role in the very end side of the spectrum. So if endoscopy or PPI is successful, you don't need surgery. But probably surgery also needed if rebleeding occurs. So a bleeding ulcer with high-risk stigmata, bleeding ulcer with high-risk stigmata who have successful endoscopic therapy receive high-dose PPI therapy. So usually loading dose and then followed by continuous infusion for 3 days. And for this high-risk patient, continued oral PPI therapy twice daily through 14 days. Then once daily for total duration. For patients with previous ulcer bleeding who require platelet or anticoagulant therapy for cardiovascular prophylaxis, PPI therapy may also be needed. And for pharyngeal bleeding, the American Association for the Study of Liver Disease guideline recommend a short-term course of prophylaxis with either oral norfloxacin or intravenous ciprofloxacin for all patients with cirrhosis who are hospitalized for pharyngeal hemorrhage. Several studies have suggested that antibiotics prevent rebleeding and decrease infectious complications. So you need to give antibiotic for pharyngeal bleeding. And to treat acute pharyngeal hemorrhage, octreotide is usually useful with a bolus dose of 50 microgram followed by 3 to 5 days continuous of infusion. And terlipressin is very useful. It's the only pharmacologic agent associated with reduction of mortality compared with placebo. So I myself have no experience in using terlipressin, but my colleague from gastrointestinal medicine, yes, they use a lot of terlipressin in cases with gastrointestinal bleeding. So for non-pharmacologic management, angiographic intervention, transcatheter embolization therapy, surgical intervention, they are useful if the pharmacologic management has failed, and also endoscopic management has failed. So these are the strategies to continue the treatment to stop the bleeding. And however, surgical intervention for the management of acute bleeding has declined in popularity, probably because more use of PPI and more use of endoscopy. So the role of surgical intervention is less today than a decade or 20 years ago. How about balloon tamponade? Balloon tamponade is effective as achieving short-term hemostasis in more than 80% with variceal hemorrhage. So it's only for temporary. You insert balloon tamponade with Stengstaken Blackmore tube, and usually it's only to delay or stop the bleeding until the patient undergoes surgery. In regard, so after the bleeding has stopped, then we should think about the prevention of further bleeding. So once gastrointestinal bleeding has ceased, once daily PPI therapy has been shown to be effective, so you should continue to give the patient PPI therapy only once daily is enough. And also patient, if they need to consume aspirin or NSAID therapy, those patients requires prophylaxis with PPI. So never takes NSAID alone without the company of PPI. How about if the patient has proven that Helicobacter bacteria involved? Then triple therapy is still effective. Triple therapy is a mixture of amoxicillin, clarithromycin, and PPI. It is still recommended for counteract the Helicobacter pylori infection. It should be confirmed at least 4 weeks after completion of treatment. And the risk of rebleeding may remain if the proper dose is not given. How about the stress ulcer? SRMD, stress-related mucosal damage. Yes, in several trials, histamine 2 receptor antagonists like ranitidine, famotidine, antacid, and PPI, they are proven to be useful. PPI are potent anti-secretory agents with effective control of gastric pH. It is more effective than histamine 2 receptor antagonists. So now we use more PPI rather than histamine 2 receptor antagonists. Okay, and these are the examples of the H2 receptor antagonists. I'm sure that you all have familiar with all these drugs, and these are very common use everywhere, anywhere in the world, I think. I think that's all that I can convey on this short presentation. As a conclusion, international consensus guidelines offer a systematic approach to the management of upper gastrointestinal bleeding, and Helicobacter pylori infection and NSAID therapy continue to be the 2 most common causes of gastrointestinal bleeding, and PPI is the most effective strategy, and endoscopy plays an important role in the management of upper gastrointestinal bleeding. With that, I thank you for the opportunity. I return the session to the moderator. Thank you, Dr. Balian. Thank you, audience.
Thank you very much, Dr. Edo Budiman, for your very clear overview of all about the upper GI bleeding. And you have talked about all the things about the upper GI bleeding, from the classification and also the risk and also the predictive scores and also the management of the upper GI bleeding. Yeah, thank you very much. We can have the question later on. You can answer it if I collect the question from the audience or from the panelists. If a burning question from panelists you can make some question to Dr. Reno, please, from the panelists.
Okay.
Dr. Rawan, please.
Okay. Thank you very much, Dr. Barlian, as the moderator. So I would like to have a comment and a little bit question to Dr. Reno. That according to, as we know that the Indonesian Society of Endolaparoscopic Surgeons is already have trained and gave the the skill for the general surgeon in the periphery area or have an endoscopic skill. Then we know that the endoscopic skill, it is very important for our surgeons in the periphery, especially in just like in a small city. And no more than 6 surgeons that can do by himself in the remote area. My question is to Dr. Reno as one of the national faculty member, because we know the national faculty member here, also the panelists here, there's Dr. Kun, Dr. Aro, and Dr. Iqbal, and also Dr. Niam is also the national faculty member for the endoscopies. My question is to Dr. Reno is, what is the minimal expectation for the surgeon in periphery and the remote area to do the endoscopies for the the bleeding of upper GI bleeding? Dr. Reno.
Yes, thank you for your question, Dr. Arawan. And I think the main purpose of doing endoscopy in upper GI bleeding cases are to stop the bleeding. Of course, it's not an easy job. First of all, sometimes in a very massive bleeding, it is very difficult to visualize the lumen because they're full of bleeding. So the endoscopy instrument have to have effective suction and irrigation machines so not only a basic endoscopic tower, but equipped with suction and irrigation. For the surgeon who perform the endoscopy, it will be much helpful if proper suctioning and irrigation takes place with machine, with pumping of the suction and irrigation very fast to evacuate all the bleeding. After evacuation, you can see the source of bleeding. So I think how to stop, actually during our endoscopic courses, we teach the participant to stop the bleeding with hemoclip and with submucosal injection. So of course, the endoscopic surgeon have to master this technique, how to stop the bleeding by applying clips or hemoclips to stop the bleeding. It's not an easy job, but once it is successful, then you avoid the patient to undergo surgery. And usually, once you have successful stop the bleeding, the dramatic hemodynamic improvement can be achieved. So I think to answer your questions, the endoscopic surgeon who perform the procedure have to master stopping the bleeding endoscopically.
Thank you very much, Dr. Reno, because now the participant is around 511, and I think from the 511, at least 400 is from the general surgeon. So in my opinion, and I hope that also the general surgeon in the remote area of Indonesia can do also at least the diagnosis of the endoscopic diagnosis, and also maybe I hope that also they can do how to stop bleeding at least, and by the diagnosis they can prevent for being bleeding in the remote area. Thank you, Dr. Reno. Thank you, moderator.
Thank you, Dr. Irawan. Perhaps from Dr. Kun has some comment. Dr. Kun Samedi is not here. Okay. So we can move. Dr. Kun, yeah. Please, Dr. Kun, have you some comment on this?
In my view, I think the general surgeon can do the scope. Even if cannot do the hemostatic stomach or in the duodenum, so can be directed if even the general surgeon cannot do the hemostatic endoscopically, when they do the operation directly to the point of the bleeding, so can cut the time and also go directly to the source of the bleeding. That's my opinion. Thank you.
Okay. Thank you very much, Dr. Kunz. My question is now is the endoscopic treatment is the gold standard, Dr. Reno, yes?
Yes.
And do you think that we have enough endoscopic surgeon or endoscopists to do this in the periphery, in the remote area?
Not in the moment currently, Dr. Valian. I think we have still a very few surgeons who performs endoscopic routinely. So, and also to stop bleeding endoscopically is not always easy, even in big cities. Sometimes, for example, in Bandung itself, it is in my hospital of the Hasan Sadikin Hospital. It's a very big hospital referral system for the West Java province. We still have difficulty in facing patients with gastrointestinal bleeding if we want to stop the bleeding endoscopically, because our instrument is not well equipped to stop the bleeding. To stop the bleeding, we need some accessories that probably will be explained by next speakers.
Yep.
That is still not available yet here in my hospital. So yes, I agree with Dr. Kunzmedi's idea. You go inside endoscopically to locate the source of the bleeding and then continue the surgery to stop the bleeding accurately. The location is accurately placed with endoscopy, but stop with surgical. I think that's the most wise strategy suitable for our situations.
Okay, thank you very much for your answer, Dr. Reno. Yes, we move on to the next speaker. I will invite Dr. Asim Sabir. Professor Asim Sabir is from the National University Hospital from Singapore, and is one of the rising stars in the endoscopic surgery in Singapore also. And today we are very glad and very honored to have him here in our program. And he will talk about the instrument which can deal with the therapy in the upper GI bleeding. This is a long list of the curriculum vitae from Dr. Asim. And if someone interested, we can send this table to the people who want to know about the CV of Dr. Asim. Okay, Dr. Asim, yes, time is yours. You have time 20 minutes to talk about the TB energy use. Please, Dr. Asim.
Thank you very much, Terry. Thank you very much indeed, the Indonesian Society of Endoscopic Laparoscopic Surgery, to Professor Balin Suteja, to Dr. Irawan, and all the other friends. It's a great morning, and it is my honor to spend that morning with you. I have been assigned today to share about the use of energy devices in minimally invasive surgery, and specifically talking about a combined bipolar and ultrasonic device called the Thunderbeat. So it's a great honor. First of all, this is your first webinar and a series of many more to come. So congratulations to the team for putting this together and having such a great participation. Now, let's see this guy. Yeah, so that's myself. I do humbly acknowledge being part of a lot of international societies, and my goodwill is education, and I wish to continue educating the masses. That is where I practice. That's National University Hospital in Singapore. We are not very far away from you. Just right behind there is Indonesia. And I'm exactly at this location, and I can see you from the far, and media has brought us close. So this is advancement in science, and one such as advancement is what I'm going to share. I have no disclosures for the talk to have. What are we going to learn today? We're going to learn some little fundamentals. All right, remember, whenever a mistake or a complication happens, it is always because we deviate from the basics. It's never not knowing the complex, because whenever you will run into a complex situation, you would always want somebody to come and help you. It is actually deviation from the basic knowledge that basically puts up in trouble. We'll talk a little about training. We'll talk about some tips in using energy devices. So the first question that when I received the talk is, why should I even consider using an energy device? I was, like many surgeons here, grown up using a pair of scissors to do all the dissection. I was grown up doing single incision surgery, which means starting from xiphoid process to pubic symphysis is just one incision surgery, which is open surgery. So why should we even use MIS surgery? When we go into laparoscopic surgery, our field of vision shrinks because the eye of the camera, the zoom and the eye of the camera can see only that much. The operating field in which we operate as compared to open field is a little bit more wetter. And what has that got to do? It basically allows current to flow. Water is a medium for current to flow. So that is not, and especially if it is electrolyte rich, like the one that we have in our bodies, it easily allows for conduction of current. Then I thought, what is my need? Why do I need, as an operating surgeon, I need to have good hemostasis so that I can see. I cannot go back to my old surgery where I can use the scissors, cut a vessel, put a gauze, wait for 5 minutes, and let the vessels go into spasm, and then hold it and tie it. I can't do that because it will be very time consuming. So I need a good hemostasis. Suture and ligation are technically demanding skills, and they are time consuming in laparoscopic surgery. In open surgery, you take an artery forceps, a clamp or whatever, put on a vessel, get the assistant, take a silk or whatever suture you want and tie it off. It hardly takes half a minute. In laparoscopic surgery, doing the same act can be as long as 5 minutes. Imagine doing a Whipple's procedure and having to do that every now and then, every 5 minutes, trying to wait for 5 minutes to secure hemostasis. The surgery will become 10, 15 times longer, which is not good for patients. So operating time, not only for the sake of saving cost, but for the time that the longer the patient is under anesthesia, the more complex the post-operative outcome of this patient. So we need an energy device to be used in minimally invasive surgery. I thought, since we're going to speak about an energy device that has ultrasonic energy and that has bipolar energy, it would be good for me to introduce you to safe energy. What is ultrasonic energy? It is basically the active blade of the blade that does not open and close. This blade stays still and this one opens and closes. So this blade, which is still, the vibrating blade, is actually the active blade. And it is important to know, as I will show you in subsequent videos, why it is important to know. What happens is when the active blade vibrates very at high frequency, it basically converts energy from ultrasonic energy to thermal energy, which denaturizes proteins in the cell, causes a sticky coagulum, and allows for safe cutting and coagulation. That's how ultrasonic energy works. Now, since we're talking here, we need to talk about bipolar energy. On the other hand, in a bipolar energy, the current passes between two jaws. And that electric current then denatures the collagen and elastin and results in coagulum formation. Once it is done, the circuit is fed back to the machine and it stops delivering current. This is an old kind of ligature that you see here being used. And this is just to show pure bipolar devices. So in summary of the concept of use of energy, ultrasonic energy is converted into a kinetic energy, which is then converted into a thermal energy for use. And the thermal energy then gives us the coagulum that we need. Now, to create a combination of cellular and tissue effects. All right. So what I am giving you now is a dangerous weapon. All right. It is just like this gun, this policeman in a police force. The gun is here supposed to save the public and not burst his backside. All right. If this trigger goes off, you know what exactly will happen to this policeman. So my question to you is, as a policeman, as a custodian of public safety, is this gentleman using the tool appropriately? The answer is no. So we as surgeons who are custodians of patient care and patient safety need to learn how to use our tools effectively, because the outcome depends upon how we use our tools. So this is a famous quote. It says that an adequate surgical training is a prerequisite to the adaptation of electrosurgery. Sometimes not knowing things is a blessing, but in energy users in surgery, not knowing the details is actually a curse. You can cause more harm than good to your patient by using it. It little behoves the novice to take up such a powerful weapon, dangerous in the hands of an unskilled surgeon. Right? So we need to train, and that's why we are gathered here together to learn, for us to share experience about the use of these deadly weapons that me and you carry, but can be very effective in the work we do if we use them safely. So the first thing when we use these weapons that are around us is to know our OR. This is an integrated OR, which is an endolaparoscopic OR that we have. I know many facilities across the world may not be able to have these, but they should be so integrated that when you put your instruments at one place, you know where is what and how they function. And as a surgeon, you take onus of all these things around. You know, it is easy for me to walk down the theater and say to the scrub nurse and scold her, why is this not working? Why don't you know how to operate this? But as a person, as an end user, do I know how to use it? If I know how to use it, I have the rights to tell people, why don't you know? But if I don't know my own things, then it's not wise. So one of these is energy devices, and be careful when you use it. When I choose an energy device, this is how I look at an energy device. Okay, we all do surgeries which can be 10-minute, we can do surgeries which are 8 hours, 10 hours, and more than that. So I need to know the mechanical properties. I need to know the technicalities. I need to know patient safety. I need to know monetary benefits. When I talk about mechanical properties or functional properties, I need to see, when I hold this toy in my hand, is it safe? Can I manage it easily? Can I grip? Is the grip in the hand of this that I'm holding, is it good for me? Will I use it for 6 hours and then my thenar eminence will be hurting and I need to go and spend $100 on a massage when I did not earn $100 from the procedure? So I need to care for myself. Ergonomics is important. So when you choose your energy device, choose something which is ergonomic for you. Choose something which is of suitable length. A patient may have a very long craniocaudal length, and you may not be able to use the normal 34, 32 centimeter devices. You may want a 45 centimeter. Make sure they're available when you choose those. In the technicalities, hemostasis. What do you want this device in this operation to do for you? Is sealing your main thing? Is cutting your main thing? Or you want sealing and cutting together? How easy are you going to do a complex operation where you need to do a very fine dissection? Can the device be used as a major instrument and allow for easy dissection? How fast can this deliver what you want it to deliver? You need to see, from a safety point of view, is there thermal spread? Then you can avoid injury. That's the tissue stick. After everything I do, I have to pull it out, give the nurse to clean it, and then put it in, wasting my time. So there is no speed. And does it really make monetary sense? Is it cost effective? Is it very highly priced? Can majority of my patients pay for it or don't pay for it? So when Thunderbeat came out, it is and probably stays to be the only integrated device which has ultrasonic energy and bipolar energy. And I'll tell you the benefits of it. Not that I have any stakes in the company or anything, but there are benefits and you need to use things wisely. It seals big vessels. The company is very proud of it. I'm not proud of it. Okay. For me, anything that has a name deserves respect. Any vessel that is named, even if it says 7 millimeter, are you and me happy to clip the left, to just cut the left gastric artery with a 7 mm sealer and say, we are happy, let's go back and sit down and sleep? I wouldn't. I would still put clips there, even though I have a great sealer. Why? Because when an infection happens, the burst pressure of a clip is much more higher than the burst pressure of a sealed vessel. And the likelihood I will lose my patient is less. So yes, look at it objectively. Don't just look at tables and say, well, 7 mil, okay, we don't need to do, we just seal and cut and walk away. I can say that. Cutting speed, it is good. When you compare it to its competitors, it's good. Burst pressure, we've talked about. It gives you the greatest advantages. It gives you a bipolar sealing without a cutting. When you do work, which is fine, where you transgress to the very small veins, you just need to capture them and burn them before you cut them. You are assured that it will not cut before it is sealed, right? The lateral thermal spread in the initial devices was of concern. The company modified their cooling mechanisms, and now I think the burn area for 2 millimeters is in place for these devices. Why is this important? This is important when you do anastomosis. When you use an energy device to create a hole in an organ, say a small bowel, and you dilate it, remember, 2 millimeters from the point you have created that hole, the tissue in 5 days will die. So if your bite size is 2 millimeters, you are likely that that stitch will erode and you will get a leak. So your minimum bite should be 3 millimeters, if not 4 millimeters on that area of burn, right? Ergonomics, for a big-handed person like me, it is a great ergonomic, and it is cost-effective in the system that I practice in. Now, a lot of people were skeptical about the use of these energy devices when they came up and said, do they really make a difference? Do they make a difference on blood loss? And if you see the study done way long back in 2005 compared electroenergy, which means monopolar energy, versus ultrasound versus bipolar, and you can see that the duration of surgery was shorter in ultrasonic and bipolar energies, and blood loss similar compared to simple electrocautery surgery. Why? Because if you bleed, you secure. Whereas with a monopolar, you have to find other means and you struggle in the intermediate, the patient bleeds. So that's important. Do these, all of them seal the same size? I've talked about sealing. Lymphatic leak. Interesting study done a long time back on mastectomy patients and showed that those devices that sealed vessels, whether they sealed them ultrasonically or through bipolar, actually had less lymphatic discharge compared to the conventional use of energy. They gave better samples for histopathologists, for our pathologists to analyze. The architectural defects that were there due to energy were minimized by the use of ultrasonic energy. Now, all right, okay, the picture cannot be displayed, that's all right. So in this video, I would like to demonstrate three things. How to use the active blade, which is the vibrating blade. I would like to demonstrate fast versus slow cutting and thermal spread to you. So follow me through the video. Really? I'm going to do this now. So, okay, guys, just give me a minute. I think the video decided not to play, cannot play media. Just give me a minute. I'll relog this presentation. Just 1 minute. Why at the nick of time does it have to do this to me?
So,
sorry, just
Dr. Barlian, please handle it.
yeah, no. I'm having some issues with my side. I've had some problems. I do not know why suddenly the videos don't want to play. The PowerPoint has given up on me.
Yeah.
Just a minute. I will trace them back.
No problem. Take your time for a while.
Yeah, I think some. A bit strange, but I do not know why.
Or we can change to Alan first, Ashim.
Yeah, maybe I'm trying to figure out where the presentation disappeared.
Yeah.
Alan, you take over, please, and I'll come back with the.
Yeah, I think so. Professor Allen. Hello. Can I invite you to the next presentation? Yeah. Professor Allen will talk about the endolaparoscopic management of upper GI bleeding. I think our participants know you already very well because you are very often in our webinar and another congress in Indonesia. But nevertheless, we must see your CV here with a lot of education program, and you are a very active laparoscopic surgeon, and we are very happy and also honored to have you here in our course today, and we are very happy to hear about your talks today. according to the endolaparoscopic management of upper GI bleeding. Please, the time is yours, Professor Alan Bunafe from Philippines.
Thank you, Barlan.
Yeah.
Terima kasih for inviting me again. Selamat pagi semuanya. It's really a pleasure of coming back, although albeit on Zoom. I was really hoping that I can come physically. Hopefully, in the nearest future, I'll be there. I'll be talking on endolaparoscopic management of upper GI bleeding. I think my work for today has been made easy because of Reno's lecture earlier on endoscopic solutions for upper GI bleeding. So I have no disclosures. Next slide. My fellow is sharing the my PowerPoint. Anyway, we all know that the upper GI bleeding would come from anywhere from the mouth going down to your ligament of Treitz. Anything proximal to the ligament of Treitz would be an upper GI bleed. Next slide, please. So it's your esophagus, duodenum, stomach, and like the lecture of Reno, the mortality for upper GI bleeding hasn't changed or hasn't improved over the past 50 years, even though with a lot of medical solutions out there right now. Next slide, please. The risk factor for having a mortality or morbidity for
Your sound.
upper GI bleeding. Yes?
You're connecting.
My connection is bad.
It's okay.
It's okay.
It's okay. Go ahead.
Okay. The most common, common factor for upper GI bleed would be your prior upper GI bleeding with anticoagulant use, usage of your high dose of non-steroidal or your NSAIDs, which is the most common type, and of course for patients who are older, of the older strata, more than 50 years old and above. The most common cause for bleeding would be your H. pylori infection, which would account to about 70 to 92%, followed obviously by your chronic NSAID use. Then other factors would follow. I think this one was shown to you by Reno earlier. Next slide, please. So just gone over my lecture because a lot of these things have been taken up by Reno earlier. So diagnosis would usually be with upper endoscopy. You do your bleeding peptic ulcer disease, patient comes in, an upper GI endoscopy is done on this patient. For massively bleeding patients where you cannot look for the stigmata of your bleeding, a CT scan or CT angiography can be done on these patients. This one has been shown by Ralph next Ralph. Ralph, next slide. Hello. Ralph.
Okay, we hear you.
Yeah, okay. Go ahead.
Ralph.
A little bit slow. Your connection is not so very good.
That would be your achieving hemostasis and stopping the bleed. And of course, reducing the rebleed of your patient and trying to assess the need for surgery and lowering down the mortality. Scoring system have been used for low risk group and high risk group. Next slide, please, Ralph. Ralph, next slide. Ralph. Okay. Non-operative treatment would incorporate the principles of your ABCD, which are air, breathing, insertion, endoscopy, and of course, only either by coagulation or electrophoresis, injection of epinephrine, and application of hemoclips. For patients with higher risk of rebleed, with stigmata of high-risk lesions, higher risk for rebleeding, a certain loop endoscopy can be done in these patients within 24 to 48 hours. Next slide, please. Next slide. So high risk, Scandinavian Journal of Gastroenterology, there's a 94% achieved rate for upper GI bleeding. Options for controlling your upper GI bleed is like your OTS or over-the-scope clip, using your Ovesco clip that was made in Germany. This is an over-the-scope. You attach the appliance on top of the scope and try to identify the bleeding site and release that Ovesco clip to control the bleeding site. There are other newer modalities available in the market right now for endoscopic therapy, which is some of these are your hemospray, your EUS guided ultrasound angiography, radiofrequency ablation, your endoclot, and your endoscopic band ligation. A lot of these things are available right now, but the role of these systems are not yet clearly defined. I think in a few years' time, we'll be able to get the evidence for this one. Other options for a rebleed or uncontrollable bleeding, you can do repeated endoscopy and an alternative of your transcatheter angioembolization. You try to identify where the bleeding site is through and that area. Would be your endoscopic treatment, but a mixture of surgery can be done on patients, especially for patients who are massively bleeding. So after a failure of repeated endoscopy, or patients coming in on hypertension and hemodynamically unstable, or patients with larger than 2 centimeters, or a repeated, even without repeated endoscopy. Next slide, please, slide. Ralph, next slide. Ralph, next slide. Randomized controlled trial study out of 92 patients and successful long-term control of bleeding. About 16.7% have been done with an open surgery. In choosing between what's best for patients right now, the evidences would show us even the recommendations for international societies for laparoscopy would be open surgery. The latest was a publication done in the World Journal of Emergency Surgery in 2020. I recommend to do open surgery. The reason I think I believe on that one upon reading it's because of the expert, the dearth of experts in control the bleed. In this center, been doing the first as open control GI bleeding speech. next slide.
Yeah, Roy, your connection.
Maybe connection from Dr. Allen is not good.
So, let me. Hello, can you hear me now? Hello?
Yeah, we can.
Yeah,
now, okay.
I'll try to go out.
Your connection become stronger.
Yeah.
Yeah, better now?
Yes,
Okay.
yes, okay.
Yeah, failed endoscopic treatment would need surgical treatment for patients. Evidence of ongoing bleeding, hemodynamically unstable patients would obviously need a surgical intervention. The choice of doing surgical intervention would either be an open one or a laparoscopic approach. And all of these things that can be done through open method can also be done laparoscopically. So for patients with bleeding ulcers, an oversew of the ulcer can be done, but this can also be done through the laparoscopic approach. Next slide, please, Ralph. So these are just paper that came out with the use of open surgery. Can be done with vagotomy or pyloroplasty, partial or total gastrectomy on patients with bleeding peptic ulcer diseases. Next slide, Ralph. I'll just go on with this one. Some of the papers are actually presented by Reno earlier. Joulefoil lesions can also be treated laparoscopically. We'll show you videos later on where we've done an laparoscopic approach for Joulefoil lesions. Although endoscopic treatment for bleeding Joulefoil can be done endoscopically, but a profuse bleeding in Joulefoil lesions, you would usually need surgical intervention. Next slide, please. So indications for selective angiography, failed endoscopic therapy, lower GI bleeding, and obviously poor candidate for surgery where patients cannot undergo anesthesia on these patients. Next slide. So surgery would always be the last option for the treatment of upper GI bleeding, only for massive bleeding and unidentified bleeding area, where we all know that the mortality is high for these patients. Gastrotomy to evacuate blood, suture ligation, and successful laparoscopic resection relies on accurate localization of the bleeding. Hence, in some areas, they do a combined laparoscopic and endolaparoscopic approach for this patient. Wedge resection can also be done. Next slide. And of course, your laparoscopic transgastric resection. So we'll show you small videos, small snippets of what we've done so far. The most worrisome of all the upper GI bleeding would be the one coming from your gastroesophageal varices. And I'll show you a video on how we manage this patient. We all know that this can be done through your endoscopic sclerotherapy or even your esophageal variceal ligation. But surgery sometimes is warranted for patients, especially for patients who would massively bleed and are hemodynamic unstable. So this is a short video of our patient. This one is a patient with variceal bleeding, portal hypertension. The plan of our service is to do a Sugiura technique. We all know that Sugiura is done through the open method. So the pleura is opened up to identify your esophagus. Sugiura technique is basically a devascularization procedure, devascularizing your esophageal area, short of doing a HASABS. HASABS, we include your splenectomy, resection of your short gastric with transection of the esophagus. Sugiura is just a removal of your the blood supply of that esophagus and transection of that esophageal area. So the esophagus now is identified, taken down, identified completely, and we do a small gastrotomy on the stomach. So that's the esophagus. A small gastrotomy is done, and through that gastrotomy, we can pass through a circular stapler going up through that esophagus. So once you're at the esophageal area, you do your ligation at the area of that stapler line, and you fire the stapler, thereby transecting and stopping the blood supply of that esophageal area. Hence, you stop the bleeding of this patient. This patient actually went home third day of the surgery with no bleeding. We do checking. We do checking of the area where we did the transection and do your repair of the gastrotomy laparoscopically. All of these are done laparoscopically. So these are just some avenues or some techniques that you can do to combine your endoscopic treatment and your laparoscopic treatment. Mind you, this patient has underwent several endoscopic procedures to control the bleeding. So what are the evidences for a combined endolaparoscopic management for upper GI bleed? So next slide. So there are several papers that came out. A lot of these papers are actually from Asia. Some are from European area. Next slide, please. So just a few videos again. Next slide, Ralph. So you can do a transgastric, a combined transgastric. This is a combined transgastric approach. You do your visualization through your endoscopic view, and you do your transection or your control of the bleeding through your transgastric approach. So combination of an endoscopic approach and a laparoscopic approach. So a transgastric insertion of your trocar is done. And identification of the lesion. So the lesion is identified through your endoscopic view. Once the lesion has been identified, you can do your repair or your control of the bleeding site through your, so this is a bleeding tumor on the side. So we did a wedge resection, a submucosal resection of the tumor with control of the bleeders, and a primary repair of that area. Can we move the... So these are just some papers that were taken from the internet showing your transgastric intraluminal suturing, which prove that it's possible to treat bleeding gastric ulcers using your laparoscopic endoluminal suturing with a good result on our patient. Next slide. So several papers that would prove your a combined endolaparoscopic approach can be done on this patient. Next slide, Ralph. So underrunning of bleeding duodenal ulcer can be done on patients. Next slide. So with the intent of giving the best option for your patient, we can actually combine the advantages of your endoscopic approach to our patient, plus combining the advances in laparoscopic procedure. So having the knowledge of how to do endoscopic procedures and laparoscopic procedures can be very beneficial to our patients. Next slide, please, Ralph. Next slide. Even for occult bleeding, a combined endolaparoscopic approach is beneficial for patients and a good assessment tool for patients. Next slide, Ralph. Ralph, next slide. So, in conclusion, next slide, Ralph. Ralph, next slide. So, several procedures have been done combining your endoscopic and laparoscopic approach, even for bypass patients. This can be done with patients without bleeding, apparently after a bypass, where you can insert your laparoscope and insert your endoscope through that the functionalized limb of your stomach. Next slide. So combining both armamentarium would actually open up a lot of advantages for our patient. So next slide. So just several papers that would show you the advantages of a combined envelope approach on patients, either with the treatment of ulcer or even with bleeding peptic ulcer diseases. Single part can also be done, but would need more advanced skills from the surgeon who's doing it. So this just a few video that we do. So endoscopic clipping of your Guilfoyle lesion, and endoscopic variceal ligation. So this is one of my patient after a total colectomy came in with massive bleeding, apparently with a small bleeder in that area. It took us 6 hours, I think, just to be able to remove the blood from the stomach using the endoscopic approach. Looking back, we could combine an endolaparoscopic approach that can actually make the procedure faster and better for patients. Even for variceal ligation, this can be done also on the patient. Next slide, please, Ralph. So again, this is how we do. We occlude first our ligament of Treitz, so that when you inflate that stomach area with gas, the air won't go through the small intestines and thereby creating some area in that obstruction in that area, preventing your movement laparoscopically. So this is just a control of a bleeder site where you can do a gastrotomy and you can do your repair of that area through your laparoscopic means, transgastric approach. Next slide, please, Ralph. Truncal vagotomy can also be done laparoscopically. Even your proximal gastric vagotomy can be done laparoscopically. But again, it involves a lot of technical skills from the operator, from the surgeon, and a lot of learning and training from the surgeons. Next slide, please, Ralph. Next slide. So just a laparoscopic distal gastrectomy for bleeding perforated peptic ulcer. This can be done laparoscopically also and can give better prognosis for patient even after the injury. Next slide, Ralph. So in conclusion, your endoscopic approach can treat majority of the acute upper GI bleeding lesions, although there's a limited data on the endolap approach. But I think with a lot of surgeons and a lot of endoscopies doing these approaches nowadays, in not so distant future, we'll be able to come up with a good data that will say that it's advantageous to our patient. Endoscopy is a good adjunct for lesion localization during laparoscopic approach, and the approach confers the general advantage of minimal invasive surgery, and of course the added advantage of your as an added armamentarium for the general surgeon. Thank you very much for your kind attention.
Thank you very much, Professor Alan Bunafe, for your excellent presentation. And I heard you must to leave earlier. Yeah.
Yeah, I'll be.
One or two questions is allowed to.
Of course, of course.
Okay. We have seen from your lecture quite nice video clips about the transgastral approach combined with the endoscopic. And how is the future of this? Is that as a best option to treat something like that?
Yeah, I think more and more surgeons are doing into this avenue where we're trying to explore the advantage of your endoscopy, combining it with laparoscopy. And I think in a few years' time, Hong Kong has been doing it for the last few years. We all know that we've been doing a lot of workshops through APELS. I think you're involved, and Erawan are involved with APELS as much as we are. All of us are doing it. And I think it's like Indonesia, where we need to train our surgeons on how to take hold of that endoscopy. I think it's one of the armamentarium that a general surgeon should know, so we can combine the advantages of both fields
Yes.
to be able to offer it to our patient.
Okay, thank you very much for your suggestion. I hope in the near future we can also, like you, to do something like that. Okay, thank you, Ellen.
Thank you
You
very
can
much.
leave now if you have something to do. Thank you
One
very
question?
much. Thank you very
One
much.
question for Ellen.
Yes, Eddie.
One question for
from
Ellen.
Dr. Erawan.
May I?
Yeah, please.
Okay. Ellen,
Yes, Eddie.
we'll talk about the
Eddie? Hello? Come again?
Suaranya kurang baik, Bang.
Devasculation for the facial day. Suara kurang keras.
Kurang
Section?
kurang kedengar, Bang.
I cannot understand the question.
Sekali lagi pelan-pelan.
Maybe signal from Dr.
For
Erawan
the
is good.
esophageal transection,
Yeah.
for
Yes.
the pharyngeal bleeding,
Yeah.
do you also treat the portal hypertension? Because
Actually,
if you don't,
well, treatment of portal hypertension are multimodality. And the reason why we did the HACCPs or the Segura is for the immediate treatment of massive bleeding on patients. We all know that the blood vessels coming from the esophagus would be through a linear on the side walls of that esophagus. So a transection and a devascularization of that area would effectively control the bleeding of the patient. But then again, because it's a chronic disease, you need to have a multimodality approach on these patients. So you have medical management, and surgery is actually one of the last methods that you need to do on this patient. We only did the Segura on the patient because the patient was massively bleeding. Then of course you have to check for the child's classification of patients. So these are the things that it's not a magic medicine for your patient. So we choose our patients, we choose the treatment that we can give to our patient. I think that's the message.
Okay, thank you very much. Dr. Erawan,
Thank you.
Another question? Last question? Because Dr. Ellen is always busy.
Okay, thank you very much. Very sorry, so I don't want to bother you again.
Okay.
I'm not bothering
Thank
you
you
again.
very much, Alan. Yeah.
You can go.
Thank you.
Yeah. See you next time. Thank you very much.
Thank you.
And we
Thank
go
you,
back to Professor Asim. Professor Asim, are you there?
Yes, thank you very much. My sincere apologies for
No
that
problem, Asim.
undesired outcome that we just had.
That is always with the modern device. You have always the problem.
Okay. So I hope the modern device is not going to give me headache. I just checked it. It was working, and actually our hospital and our internet has separated now.
Oh.
Yeah. And this is because of
Saturday.
No. We have gone separate ways. And it is because just 1 minute, sir. I just checked it. Because of a lot of problems with the internet, they actually stopped everything. A lot of people jumping in to get. Don't tell me. Why? I just corrected everything. Just a minute, please. Oh, this is so painful. Sorry.
Asim, is it possible to answer some question from the panelists during this
Yes,
time?
certainly. Just 1 minute, and I think I've got it. up? Yes, I can answer as well as we go along. I'm just not sure why I'm so dead today.
Oh yeah, no, it's good.
Okay, is that all right?
Yes, yes, we can see it. Very well.
Okay, all right. I apologize. So what Singapore has done is our hospital, university networks are separate from the world. So no hackers can hack in. So this, they just shut down things and it becomes very difficult sometimes.
Oh.
All right. So here we were talking about use of energy devices, and I said use of active blade and thermal spread. And let me show you a video. So your energy device should be your right hand because you're using it in the right hand. You can see I can do traction with it. I can do dissection with it. I can do cutting with it. I can do whatever. So it should replace the instrument in your right hand. So you should be able to dissect. And this is for ease of procedure because most of us are right hand dominant. So a device that helps with that is important. And you can see that whenever I do, I would either keep my active blade, which is the blade in the bottom under direct vision, or if not, I do not see the posterior part, I will always keep it anterior. This use of this device blindly, if you put you can see I just turned the device, the active blade upwards. If you turn it the other way, you may injure something behind and it will either bleed, perforate, or some complication will happen. Now you can see here demonstrating the use of Thunderbeat to do fine dissection. And look at thermal spread. You can see that within 1 millimeter to 2 millimeters of tissue, there is a collateral damage that is happening. It may not be pronounced right at that point in time, but this is how it happens. The other advantage that you would want to do is that when you want to track the tissue, that means you put your energy device and pull it a little bit. You need that little grip, which this rugged sawtooth shape of the Thunderbeat provides. In harmonics and other allergy devices, the surface is rather smooth and tissue slips very easily. So you will notice when you catch tissue and try to cut, tissue actually slips out. And that sometimes becomes dangerous because you can bleed from a vessel. Again, what I wanted to demonstrate here is that it helps you in dissection, but it's not the ultimate dissector. You still need other tools to support the use of this device. When we go on, you can see here, I wanted to show you some thermal spread, and this is, let me just go through using clips. So as I made the first comment, I am a firm believer that Thunderbeat or any other device for that purpose can seal 7 millimeters. But if there is a named vessel, in this case, this is the right gastroepiploic, I always put clips on it to give me that extra sense of safety and prevention if there is an infection of the coagulum going off and causing problem. So do you see this collateral damage that I'm trying to show you and thermal spread? You can actually, if there's a slight bleeder, just use the hot blade, put it on that bleeding area, and it will just stop if it's just a oozing vessel. Now, does it allow for tissue dissection? Fine dissection and cutting. I would like to emphasize here, it is how we use the energy device, especially the ultrasonic devices. You can either cut slow or fast. If you want to cut and use your energy device fast, use half the blade. No matter which ultrasonic energy device, you will get a tissue cutting which is very fast. You can see here, very fast. The thicker, the longer a tissue you grasp, the longer the time it needs to seal. So if you want a fast one, just take a small snibble bite here and just a zip, and you get it through. You can actually open it half length and just keep going, and you can actually just slip your energy device through and it will open up the entire space for you. So this is a distal gastrectomy. What I'm doing here is station 8 lymph node dissection 8A for the distal part near the common hepatic artery, as you can see. And this is basically to show you that it allows for a very fine dissection, even to the level of minuscule vessels that you can hemostase. You can see that lymphatic running there just now that I actually secured with the hemostat, with the ultrasonic device. This is station 8A that I have done in this patient. Now here is fast cutting. This is a patient with a sleeve gastrectomy. And I will show you, you see here, I just grab huge amounts and just go cutting. I don't need to worry because this curve of the stomach is going to come out. So once this term, going to come out, I don't need to worry about collateral damage. I just need to care about speed so my patient can be extubated early. A great property of this device, an advantage of this device, is to do coagulation, bipolar coagulation. You see in this region that I have just pointed out, there is the splenic artery. I'm doing a dissection of lymph nodes along the splenic artery. There is a splenic artery. And if you use ultrasonic energy, there are so many small perforating branches that are actually going to the pancreas that if you do any hasty movement, you would destroy the next vessel and it will bleed. All right. So you bipolar them and then you continue to use this. When we use ultrasonic energy devices, we need to be careful that this blade, which is transmitting the ultrasonic energy, creates a cavitation effect in front of the blade. If the cavitation effect, it can blow a hole in smaller vessels. So when we use this, we got to be very careful. And here you can see I can do bipolar burning there, you see, and then use harmonic, the ultrasonic energy to cut the thing. I burn and then I use ultrasonic energy and I cut the thing. And this is a great advantage of this device. You can secure small vessels. Here is another example, and you can then proceed on with surgical intervention. Okay, this is a patient with a proximal gastrectomy, and you can see what I was trying to demonstrate all this while in a quick motion, the use of the device, the way you can use the device, the speed at which you can use the device, always keeping the active blade in front of you, achieving hemostasis through bipolar energy devices, and rapidity of surgery and quick and successive hemostatic surgery that you can achieve. So this is a proximal gastrectomy taking place, and you can see here clear evidence that it allows for a great dissection, a great grip for our patients. All right. With that, I would like to thank you, and I will take the questions. I know I had one question from Dr. Rushdie. Dr. Rushdie, let me just go to that question. You said that you found in a journal comparison between Thunderbeat and they were equally safe and effective, and cost being very similar. How do you choose? So what I do is my own personal preference is to use different devices for different procedures. I prefer to use for my gastrectomies and for my complex bariatric surgeries, ultrasonic energy devices. It helps me create that cavitation effect that I need. It gives me greater control, finer dissection ability, and I like to add a bipolar on it, and that's why I prefer to use Thunderbeat in these cases. As far as cost is concerned, costing in different countries is different, and that's why I said you need to see how the costing in your country is. In my country, the costing is different. That is what I would have for you, Dr. Rushdie. If there are no other questions, I'm happy to take questions from the floor. Sorry, Dr. Balian, I think you are muted.
Thank you, Professor Asim, for your excellent lecture to show us the proper use of the modern energy device. But I think beside of the advantages is something dangerous is inside also. So you please tell us how to avoid the complication during you use this kind of very sophisticated device. What is the training, or is the information from the company, or what is the major the important thing to avoid the complication during you use the modern device?
So I would not discard the need for training, and familiarity with the device is the utmost important thing, because it is a tool in the entire process. So know your device. In general, for ultrasonic devices, because the main energy used here is ultrasonic energy, be very mindful that the active blade transmits energy for about a 2 centimeter distance beyond the tip. It can cause unknown injury if you do not use it in the right way. So always keep the active blade in front of you. And if there is suspicion of any injury, look for it, repair it. Don't ignore a white patch on the surface of an organ as just a trivial thing, because the depth of energy penetration is about 2 to 3 millimeters, enough in 5 days, 7 days to blow a hole in a hollow viscous. That's number one. 2, a very common habit is when we do the energy device, after that we start looking at other things, and this energy device is touching other organs. It is very hot. Whichever ultrasonic energy device you take, that can be from Johnson & Johnson, from Medtronic, from Olympus, all the other companies, even bipolar is hot. I wish I could have shown you earlier that even a bipolar can result in diathermy injury, in a collateral energy injury. Even LigaSure has that property. So be very careful. Always, if you want to cool down your device, maybe on the omentum, cool it down, or touch a structure that you're going to excise. Don't touch a part to cool it down on a part that you're leaving behind. I have personally managed diathermy and energy-related injuries, and people have just touched it. When I review the video and they say, the surgery went very well, everything, I have a recording. Can you look at it and tell me why? And I tell them, look, here, your energy device touched the organ, the small bowel. It was there in contact. There is a white appearance on the serosa, and the contact time is too long. It's equal to a burn through the seromuscular layer. And then there's a hole. And then that has delayed day 7. So these are some of the things. And last but not the least, let the energy device do its job. Okay, what do I mean by that? Okay, if this is a tissue, I hope I get the camera right. You put your energy device, meet the tissue at its tension. Don't do this. Don't try and use the energy device and raise the tissue to cut faster. It will cut faster, but it will not hemostase well. It will either bleed or cut halfway, and it will cause problems. Do not press it down like this and try and cut. It will cut faster, you will get. But if you genuinely want to cut faster with good hemostasis, take a small bite and discharge the device, and it will give you a fantastic outcome.
Thank you, Asim, for your good advice. Perhaps from our panelists have some comment or question, please. Dr. Iqbal, please. You use quite a lot of modern energy device in your clinic, I think. Can you comment on it?
I think I want to ask to Prof.
Asim
Shabir.
Yes, Mr.
But is it not from bleeding in upper GI, but I want to ask you, for dissection is lymph node, for example, in recolectomy, which one you choose? Energy device, this ultrasound or advanced bipolar, to prevent the silos after dissection? Because if in my experience, if I with the ultrasound, the patient is silos ascites after that, if I dissect in lymph node. But in advanced bipolar, I use the ligature. It's not it's safe for dissection, not the silos after that. What is your opinion? Which one is the best, with ultrasound or advanced bipolar for dissection the lymph nodes?
Yeah. So I think both are equally efficient. It is the technique we use. Your experience comes from colectomy. My experience comes from doing the lymph node dissections along the great vessels of the stomach. And I would like to share that the station 8A, which is on the common hepatic artery, is notorious for the same complication that you are mentioning. Okay, in bipolar, why is there the difference, or the perceived difference, I must say? The perceived difference is because in bipolar, you have to wait. You have no choice but to wait for the circle, which means the machine will go till the machine says, you will not trigger the cut. Right? But in an ultrasound device, you put and you go, then you start pushing and trying to make it faster. And what happens is that the last bit of the lymphatic tears off. I used to have the same problem. When I said, bipolar, very good, never lymphatic leak. But when I use ultrasonic, how come there is lymphatic leak? And then I started putting clips there. And then when I look back at my videos, I realized, whenever I go there with an ultrasonic device, I become impatient. I want to cut it very fast. Okay, and that actually only seals half the lymphatic. The rest half of the lymphatic is torn off, and then it leaks serous fluid all around. So now what do I do? If I have to do these difficult cases and I want to do them with ultrasonic devices, I will use something like a Thunderbeat, seal it with the bipolar, and then cut, and you get similar results.
Oh, very good idea. Very good idea. And some other comment from the panelists or from the participant, okay? Dr. Reno, perhaps?
Yeah, thank you for your nice presentation, Prof. Asim. I just want to share my experience in accepting referring patient from general surgeons. At least I have 2 cases that from laparoscopic cholecystectomy, biliary injury. I think the cause is that what you explained earlier, that it's the thermal injury that caused the biliary leakage. So the message is very clear. Be careful. Do not ever use the energy device to dissect or to retract other organs. Only use it for coagulation and cutting purpose, not for dissecting tissues. I think I just want to add the comments to your tips. Thank you.
Thank you very much. That's really valuable insight, and I always like to emphasize this, that injuries do not happen because we make blunders. Because when you make a blunder, you can see, right? You take a scissors, you cut half into the stomach. Everybody who's operating will you see and say, there's a hole, why don't you close the hole? Injuries happen when there are small problems, when people fail to perceive the basics of use. And then you realize, come back day 7, there is a hole. Why should there be a hole? I did a perfect surgery. Yeah, but you did not use the perfect way of using the energy device. You created the trouble. It was just waiting to happen. Dr. Erawan wanted to say something.
Thank you, Dr. Asim Sabir. Asim, I just want to ask you, if you are in the doubtful condition to predict about the diameter of the vessels, are you or you are not to directly cut, or you have make some clipping first, then you cut if you in doubt doubtfully in the diameters of the vessels?
Thank you very much. That's a really great question. As I said at the beginning of my presentation, any vessel, no matter how small, for me in upper GI surgery, the smallest vessel is the right gastric artery. Even that artery, as long as it has a name, I respect it. I will always clip it, and I will explain why. And then you can use a scissors, you can use an energy device, whatever you use to cut it. If it is an unnamed vessel, but it is sizable, you may choose, but I would always clip and cut a sizable vessel. Logic. The logic behind it is if the surgery post-operative outcomes are uncomplicated, you will get away with it. If there is an anastomotic leak and that infection comes anywhere near a vessel that you have sealed and cut with an energy device, be it bipolar, be it ultrasonic, be it LigaSure, Harmonix, Thunderbeat, any device, the infected area has the ability to dissolve the coagulum within 48 hours. You will have a vessel that will blow out and major hemorrhage. And if you have put a clip, it is foolproof. It's a mechanical pressure. You are not relying on tissue properties to save you. That's my take, and that's why I respect the way I do it. Thank you very much. I hope I've answered your question, sir.
Thank you, Asim.
Alan or Iqbal, have you another question?
No question, but I think in endolaparoscopic surgeon, I think we must use all of the like the bipolar, harmonic. I think is in hospital have in Indonesia must have all of the energy device to save the operate the patient, because harmonic is sometimes for the coagulation is ultrasound sometimes in coagulation is not good. We use the advanced bipolar like LigaSure or like the Ensil. Is it I think my opinion, Dr. Muriat. For the liver resection, we must have the TUSA for that save the patient not bleeding. But I agree with Asim Sabir. I always I'm in colorectal surgery. Sometimes I don't believe with the bipolar, advanced bipolar like LigaSure, but Medtronic say is safe for the not clip, but I always clip the vessel.
Yes.
After that with bipolar.
It's good.
Yeah. So I think you've brought up, Dr. Iqbal, you've brought up a very valid point, okay? And my analogy is very simple. Can you eat laksa with fork? You may be able to eat the noodle. You may be able to eat the tofu in the laksa with the fork, but you cannot drink the soup with the fork, right?
Exactly.
So that's the wrong instrument. So when you do the right thing, match it with the right instrument to do the right thing. We all have our dues to our patient, and we should use the right thing. If it's the right thing to have a bipolar ultrasonic, it's right. If it's not right. That's it. Use a different one. Sometimes you may just even not need it. And we should stick to our ethical practices and use the best tool for our patients in operations.
Yes. Dr. Allen, Dr. Berlian, Dr. Allen still join?
Yeah,
no, he's already left.
No.
He left.
Yes. But I
So
think
on one of the questions that Erawan put to Alan, it's gone for publication and we are waiting the outcome of the publication. If you have a practice where you don't have endoscopy services, okay, and you run into variceal bleed and you cannot stop it, you know, the easy way is in the left hypochondrium against the tip of the 10th costal cartilage, make a 5-centimeter incision, go into the peritoneal cavity, take 2 Babcocks, pull the stomach up, make a 4-centimeter incision, put a glove port into it, put a camera inside it. You can see the G junction right in front of you. Take a suture, ligate all the varices from there. You're done. 20 minutes, you come out clean. You don't need to waste 7 hours calling an endoscopist to come and fix your varix. You do not need to always worry whether my band has worked or hasn't worked because I do not know how to do it. So in practices which are I'm saying if you do not, don't get me wrong, yeah? If you do not have a specialized endoscopy service and you need to stabilize your patient, it's a very simple single incision transgastric procedure. We have described and published Cameron ulcers, submucosal tumors, bleeding varices, and everything. So our last series is going to be out is the bleeding variceals, where even Sangstaken Blackmore tube fails. It's bleeding so profusely that the endoscopist cannot see. Just make a 5-centimeter cut, left hypochondrium, tip of 10 costal, the stomach, go in, be a surgeon, do your job, get out. Then the rest is up to the hepatologist, whether they can do tips, they can do transplant or whatever. You will save the life of a patient.
Like a stitch, right?
Yes, a stitch. You can see the varix going in because it bleeds at the G junction, right? If you pull it slightly down, the squamocolumnar junction will come into the stomach and you just stitch. That's it, done. If you do not want to stitch, spend $20, use a V-lock. You don't have to knot it even. So don't worry if you don't know how to knot. It's just use a V-lock, take it, put it in, chuk, 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 overrun the vessel, off you go.
Yeah, so make a stitches then.
From Professor Allen, from Professor Asim.
Yes. You are a really surgeon.
There's a real surgeon who know how to do with the situation. Okay, another question or another comment?
Dr. Berlian, I want to ask to Dr. Maybe to Dr. Reno.
Yeah.
Dr. Reno, I have a case, maybe 1 week. I did the proximal gastrectomy and then anastomosis with the stapler in gastric to the esophagus. In this day, my resident consult the anastomosis is bleed in esophageal gastric. Any tip for me to the treatment person to clip the bleeding in anastomosis, or we use stent or another option? I do for the patient. I did the laparoscopic, and this day in anastomosis is the bleeding. My resident consult to me. So maybe any option for me is we endoscopic injection or clip or another option. Jadi pasiennya seminggu yang lampau saya operasi, Dok. Sekarang bleeding di anastomosisnya.
Yeah, I think stent is not an option for this case because you perform esophagogastric anastomosis where the diameter of the esophagus and the stomach are usually a very big difference. So it is difficult for the stent to hold its position to tamponate the bleeding. So the best course, if you want to do it endoscopically, maybe you can try to apply hemoclips, like with what Alan's videos earlier. It shows how to stop the bleeding using hemoclips. But if it failed or you don't have any hemoclip in your hospital, probably yes, it is best to perform laparoscopically. Of course, endoscopy will help the location of the bleeding, and then you can go in from laparoscopic view to stop the bleeding with suturing. I think, in my opinion, that will be the best strategy to stop the bleeding. But I wonder, the bleeding has occurred only 1 week after surgery, right?
Yes, after 1 week after surgery.
So it is not direct bleeders soon after surgery, but I think it's the anastomotic stapling failed to maintain the anastomosis properly, I think. So I would go enter endoscopy to locate the bleeding and then suture the bleeding with laparoscopic approach. What do you think? Maybe Prof. Asim has another view on this.
So I will take the best scenario and I'll take the worst scenario. Okay, the best scenario is I have endoscopy available to me, I have interventional radiology available to me, and I have all surgical opportunities available to me. And I'm assuming that your anastomosis is using a circular stapler. Am I correct to say that, Dr. Iqbal?
Yes, with the circular stapler is from 25 from 25.
Yeah. So this is basically a delayed hemorrhage. This is a delayed hemorrhage. It's not a reactionary hemorrhage. It means it is from the sloughing of the coagulum that has formed around the anastomosis, and the neoangiogenic vessel has actually ruptured and it is bleeding. Now, when you look at it in this way, if I have the opportunity, I agree with Dr. Reno that I would try endoscopic intervention. I would largely use mechanical things to coagulate, like put a clip. I may not be so brave to put a lot of adrenaline. I will certainly not use a heater probe and burn on a titanium staple and make a hole in my anastomosis. So my choices are limited. If I go in endoscopically and I cannot do anything, my next backfall is I will send to interventional radiology and see if but I will put a clip near the suspected area small so that when you send to interventional radiology, they know exactly where the bleed is, because it may stop bleeding by the time the patient reaches there, and they can use the clip as a reference point, and they prophylactically embolize that vessel that's supplying that area. And then the blood supply goes by diffusion, anastomotic leak will not happen. If I do not have endoscopy, if I do not have surgery, and it is, you are 100% sure this is an anastomotic bleed, I will bring the patient back to my operating room, laparoscopically use a suture and overrun the entire anastomosis. I will not open the anastomosis, because at this stage, if you open your anastomosis, you're basically fixing yourself for a leak. 1 week down, nature has mobilized all the cells that produce collagen the collagen matrix, the stromal tissue is all loose and soft, you are basically fixing yourself for a leak, a deadly leak. So just overrun the entire anastomosis. If you have the luxury of just a diagnostic scope, put the scope through, you can see where the bleeding point is laparoscopically. You ask your guy to point the scope, you can see in a dark point, just take a suture, just overrun that area and you'll be fine. I've done it, been there before.
Okay.
Asim, that's an interesting point that I caught from your talk just now, that you go for interventional radiology to stop the bleeding. I wonder what will happen to the rest of the anastomosis perfusion, because yeah, I'm worried that the interventional radiology can stop the source of bleeding, but it may compromise the other perfusion to and the rest of the anastomosis. What do you think?
Okay, so I 100% agree, Dr. Reno, with you. What I was trying to suggest is a super selective embolization. So it's like you know, when people do duodenal ulcer mobilization, the gastro called me so many times and say, "Oh, we embolized the GDA." I said, "What difference does it make if you embolize the GDA?" Most of the duodenal ulcers are on the superior wall of the duodenum, supplied by the duodenal branches, which are branches from the common, from the hepatic artery proper. So you embolize the GDA, no big deal to me. Right? So it has to be super selective. That's why I said we should put a clip there so the interventionist can see, oh, this small tiny vessel is going, I just need to take out this small tiny vessel. And the intervention radiologist can do that, in which case you do not compromise blood supply to the entire. But I would certainly agree that a blanket embolization is not what I would advocate. And if my radiologist wants to do it, I would not let him.
Thank you.
Okay. Maybe Dr. Tsumaro have some comment. Please, Dr. Tsumaro.
Dr.
Tsumaro, yeah. Please, if you some comment or
yes, speak in Bahasa Indonesia, Dokter.
Okay.
I very agree with Dr. Reno because I have any experience in my hospital. Bleeding from duodenal bleeding, then we consult the radiologic intervention, then perform coagulation, then the site of anastomosis become leak. It not recommended for, and the other side maybe because of the collateral or arcade, this is not recommended for intervention radiologic for coagulation.
Okay. Thank you, Dr. Ahmad Tsumaro, for your comment. And some other comment or question, please. Because the time is now 20 minutes over the time we have used. Dari partisipan masih ada pertanyaan from the participants? Some question I didn't see from the participant. And Dr. Iqbal, some more question?
Pesan buat partisipan aja, Dok.
Yeah, please.
In bahasa.
Boleh.
Jadi buat partisipan untuk satu perdarahan saluran cerna bagian atas seperti di gaster. Jadi pendidikan kita itu mengajar laparoskopik dan endoskopik. Jadi itu harus bisa kita laksanakan kedua-duanya. Jadi saat kita jadi di hybrid kita mencari perdarahan perendoskopik, kalau tidak terlampau mahir untuk pasang klip atau injeksi, kita bisa langsung ke laparoskopik, like the Dr. Allen, combine with the transgastrik, transgastrik. Jadi saya harapkan harus aktif endoskopiknya di rumah-rumah sakit, karena saya kira rumah sakit daerah sudah punya endoskopik gitu. Dok, pesan saya saja.
Ya, terima kasih Dokter Iqbal, thank you very much. Jadi artinya tugas kita adalah lebih banyak mendidik dokter bedah untuk bisa melakukan gastroskopi gitu ya, Dokter.
Iya, karena penyakit dalam pun saya banyak dikonsulkan juga dari penyakit dalam untuk endoskopik. Jadi bukan dari dokter bedah saja, itu pengalaman saya gitu, Dok. Jadi maksud saya ambil contoh itu hampir rumah sakit daerah itu punya endoskopik yang tidak terpakai. Jadi tolong dimanfaatkan dengan segan-segan latihan. Kalau apa-apa kan bisa dipanggil gitu maksudnya.
Baik, terima kasih. Itu tugas kita di dalam masa yang tidak terlalu jauh lagi dari sekarang, saya kira. Ya, karena endoskopi bisa dibeli oleh banyak rumah sakit, tapi orangnya yang belum bisa melaksanakan. Baik, terima kasih. Sorry Asim, I talk in bahasa. Sorry. So,
No
okay.
problem, please.
I think the time is limited. Some other comment or question, Dr. Erawan?
Bicara sebentar boleh? Ya, oke. Allow me to talk in Indonesian.
Please go ahead.
Oke. Sorry, jadi oleh karena itu makanya Perhimpunan Bedah Endolaparoskopik itu kita mempunyai juga seorang koordinator untuk pendidikan endoskopi. Dalam hal ini koordinator untuk masalah endoskopi itu Dr. Iqbal Rifai. Karena dulu Dr. Reno, sekarang Dr. Reno kan sudah menjadi wakil sekjen untuk PBI. Nah, jadi saya kira itu saya menghimbau kepada teman-teman sejawat dan saudara-saudara saya para ahli bedah umum di daerah, di mana memerlukan endoskop, di mana memerlukan skill, silahkan bisa daftar ke Mbak Linda atau ke PBI untuk melakukan pelatihan. Kapan pelatihannya, di mana pelatihannya, siapa yang melatih nanti akan diatur, disesuaikan dengan wilayah masing-masing. Saya kira saya tujukan ini terutama bagi teman-teman sejawat, khususnya para ahli bedah di daerah. Dan memang PBI itu memang tidak hanya masalah laparoskopik, tapi juga masalah endoskopik. Saya kira demikian. Ada tambahan mungkin dari Dr. Reno?
Silakan Dr. Reno.
Ya, saya kira ya memang surgeons yang kemudian menggeluti endoskopi masih sangat sedikit ya. Dan kita dari PBI tidak henti-hentinya bekerja sama juga dengan Kolegium Bedah untuk terus melatih para surgeons untuk semakin skillful dan memperoleh kompetensi endoskopinya. Jadi silahkan siapapun yang berminat, kami welcome sekali kalau Anda ingin belajar lebih dalam mengenai, terutama mengenai terapeutik endoskopinya yang mungkin masih sedikit sekali bisa menguasai. Boleh, jangan segan-segan hubungi kami, hubungi Dr. Iqbal, hubungi saya, silahkan. Itu saja, terima kasih Dr. Erawan.
Ya, 1 menit Dr. Iqbal, silahkan bicara.
Ya, jadi gini maksud saya kenapa kita dokter bedah harus menguasai endoskopik di luar kasus yang perdarahan. Jadi ini saya ambil di contoh di M. Jamil. Itu kita hampir jarang lagi melakukan laparoskopik LCBDE dan ERCP dan LC. Tetapi itu kita lakukan random force. Jadi tidak 2 tahap karena kita tetap laparoskopiknya, kemudian batu di CBD-nya kita random force. Jadi saya ambil contoh, kita masukkan wire dari ductus cysticus, nanti kita ambil parkir dengan skop donoskop, batu kita ambilkan, jadi one state. Jadi kalau dokter bedah bisa mengejarkan kedua-duanya, yang dulu algoritma RCP baru LC atau LC baru RCP, kalau kita bisa menguasai dua-duanya, bisa kita lakukan 1 tahap. Jadi itu banyak yang kita lakukan di M. Jamil, 1 tahap, mungkin Dr. Niam juga gitu. Jadi sehingga sangat jarang sekali kita melakukan yang LCBDE. Jadi RCP gabung dengan LC. Jadi saya harapkan dokter-dokter bedah kalau mau ya itu kita latih gitu maksudnya. Itu aja Dr. Erawan.
Baik.
Terima kasih.
Silakan Dr. Erawan.
Dr. Balian.
Mas komen, silakan. Selesai? Masih ada? Komen yang lain?
Dokter,
Ya, silakan Dr. Sumaro.
menyambung Dr. Iqbal Rifai, di kami kan ada banyak pejabat yang berobat dan mereka memilih satu tahap biasanya. Laparoskopi langsung ERCP ekstraksi batu.
Ya.
Dan itu pada kasus-kasus tertentu sangat membantu, terutama untuk para pejabat yang maunya cepat selesai tindakannya. Sangat bagus, Dok. Saya setuju dengan Dr. Iqbal Rifai. Memang harus selektif pasien dan ada syarat-syarat tertentu apa yang didulukan, laparoskopinya atau ERCP-nya, nanti melihat situasi. Terima kasih, Dok.
Terima kasih. Saya kira waktu juga sudah membatasi kita, sudah lebih dari 30 menit dari waktu yang disediakan. Saya akan coba untuk menutup acara webinar pada siang hari ini. So, the time is limited, Professor Asim, so we must close our webinar today. And before it, I would like to thanks again to all the faculties, to all the participants, and also the panelists with the very active interaction between the lecturer and also the panelists, and also to our supporter collaboration from the Olympus. I would like to thanks again and for your support, and also for the organizing committee for their hard work. Thank you very much, and we will see you again next time. I hope not a very far future to have another seminar or webinar, and I hope not like now online, but face-to-face more better. Stay healthy, and thank you very much. And before it, I would like to request from the MC to make a good picture from us.
Thank you, Doc. Before we take a picture, I think we have a video from Olympus.
Oh yeah, please.
Today, healthcare professionals are treating patients in a variety of clinical settings and have a multitude of clinical options and needs. We understand that as technology advances, the interest in medical education and training remains high. Welcome to a new website from Olympus. In line with our diverse product portfolio, we have compiled a broad array of educational resources designed specifically to support the advancement of treating patients in every setting. Accessible from all devices, relevant at all stages of your practice, Olympus is here to support you. Visit www.olympusprofed.com.
Terima kasih. Silakan.
Okay, thank you for that video. Thank you very much to our speakers and panelists for addressing this interesting topic and broadening our knowledge on upper GI bleeding prevention and management. Before we close today's events, let's take a picture together. If everyone could kindly turn on your cameras, that would be greatly appreciated. I think we have Dr. Julius, if you could please turn on your camera. And Dr. Kunsamedi, if you could please turn on your camera as well. Okay, big smiles. I think we have it. Thank you, everyone. Thank you so much.
Thank you very much.
Thank you very much. Good
Thank
day.
you. Have a good day.
Thank you very much,
Thank
Ashim.
you.
See you
Thank you,
next time.
Asim.
doctors.
See you next time.
Thank you. Thank you, Professor Alan.
So goodbye, everybody. Thank you very much, Asim.
Thank you,
Thank you very much.
Thank you for the
Thank
honor.
you. Thank you, Prof. Asim, Dr. Balian, Terawan.
Terima kasih Dr. Reno,
Oke.
Terima kasih, Dr. Reno, Dr. Iqbal,
Maro, Dr.
Kasih,
Iqbal.
Dr. Kunsmedi, dan seluruh peserta. Terima kasih.
Terima
Terima
kasih
kasih
Pak
Dr. Irawan.
Ketua,
Ya,
Bapak Wakil Ketua, Bapak Moderator. Terima kasih.
ya, terima kasih Dr. Sumaro. Sampai ketemu di lain kesempatan. Thank you very much.
Thank you.
Kita leave, ya Iqbal.
Ya, oke, siap dok.
Ketemu di Bali ya.
Ya dok, siap dok.
Yuk.
Tong Bangor gitu.